Thank you very much, Svindas. It was a great experience this morning with the live case, and also I'm very honored to share with you the low-risk TAVI data and the implications in our practice on a forward-going basis. Now, I would like to start with my conflict of interest, as we usually do, and no one really could have expected the rapid TAVI technology evolution, the TAVI procedural refinements and simplification, and the avalanche of TAVI clinical evidence, the acceptance of the heart team and the best practice concept, dramatic reduction in complications, and improved clinical outcomes. This success was driven mostly by standardized and consistent patient selection, procedural best practices that were developed and used globally, and the use of CT sizing for better valve selection. These steps actually in the established markets, and here you can see as an example 3, dropped the rates of early mortality to numbers below 5, a great success of the community following certain rules. A brief history of TAVI is shown here, the most important and most relevant ones for us. The first TAVI implant 2002, the first CoreValve implant 2004, and then 2019 as the end of all the randomized trials, the FDA and the European agency approved for low-risk patients. And remember, altogether, more than 24 TAVI randomized controlled trials. In the US alone, more than 19,000 patients have been enrolled, and importantly, with multiple generations of 4 different TAVI systems. So we started, as you all know, with extreme risk, followed by high risk and intermediate risk. And last but not least, very important here for the discussion, the low risk trial that has been very important. Why is this important? Because the holy grail is the 80% of aortic stenosis patients receiving surgery are and were in the low risk category. Because once we want to tackle this group, we have to make sure that we're doing things right. And if we look at the TAVI for low-risk trials, here an example for the Evolute low-risk trial in Partner 3, they support the safety and efficacy, and notably in the first month, all-cause mortality, as seen here, was 3-fold higher in the SAVR arm than in the TAVI arm. Altogether, here you can see 4.4, 6.6, excellent results. Basically, this was mirrored in the Partner 3 trial, so we are very confident. And also, TAVI hemodynamics still beat surgery, as shown here in CoreValve, and also, however, a little bit less in the balloon expandable valve. The moment how important that was expressed by this iconic person, Dr. Eugene Brownwood, at the ACC of 2019, when the results of the low-risk trial were published. He stated, "This is a historic moment, and all of us here should remember it as such." No one could have better expressed what exactly that meant in aortic valve disease. The good results in Evolute and in Partner 3 eventually led to the approval by the FDA and by the European Society, by the European Agency, and approval for low-risk trials. Does this mean we're ready for prime time? I would like to mention some caveats. First, very important, low risk doesn't mean young age, and you all know this is very often being confused. And equally important, if not more important, who was left out? And this is maybe a little bit of a cherry picking for the TAVI morphology, bicuspid morphology, and severe coronary heart disease were basically not included in the trial. So therefore, once we go into the lower risk patients, there's a shift of focus. Initially, when we're dealing with the elderly patients, the procedural success matrix were mortality, quality of life, and conduction disturbances. But now, getting into lower risk and potentially younger patients, lifetime management metrics are more important. That is to say, hemodynamics, patient possessing mismatch, durability, and life expectancy, and coronary access. So basically, what's next? Lifetime management, valve durability, coronary access, and bicuspid anatomies. As we all know, during all the trials, the average age came down now with the STS score. You can see here from 11 down to 3.8 STS score, and in blue, the mean age from 83 to 74. But we're still not in the 60s. Current ACC and AHA guidelines are shown here. TAVI is preferred, age more than 80, less than 10 years life expectancy, and surgery is preferred, more than 20 years life expectancy or less than 65 years of age. Between 65 and 80, it is really a individual decision on individual patient between the heart team where surgeons and interventional cardiologists weigh the risk, which treatment is better. I think this is a very important statement. If we look at the durability as one of the lifetime managements, you can see here on the left side, XT was not doing so well compared to surgery. With S3, however, you can see the numbers are the same. Notion trial, core valve, first generation, started in Denmark, moderate or severe hemodynamic SVD, structural valve deterioration, way superior, 14.1 versus 28.5 of even the first generation core valve. But the TAVR in younger patients, the data are limited. So we still have to wait for the results. But we know from the surgical literature that younger age and implant is at risk for earlier valve degeneration. So we have to be very careful how we express ourselves. And therefore, we are focusing on structural valve deterioration in the VARC-3 update. And you can see very importantly here, moderate hemodynamic valve deterioration and severe hemodynamic valve deterioration. Very important difference. And here you can see, as an example, in the core valve trial, HVD, hemodynamic valve deterioration, occurred more often in surgery than in TAVR patients at 5 years. Patients with HVD had significantly higher risk of 4-year all-cause mortality of valve-related rehospitalizations. Very important statement. So together, if we look at younger patients at this stage, there's a multifactorial assessment for current practice. The heart team, and we know that there are factors related to valve durability, both patient-related and prosthesis-related. We have to be careful. Moving on to bicuspid aortic valve disease, we know there's a novel classification system. Patients or bicuspids with no raphe, non-calcified raphe, and calcified raphe. We know from recent studies that the more calcium they have, the higher the mortality. So there's a direct relationship with the amount of calcification and the raphe in relation to mortality. If we also look at the low-risk bicuspid patients, they were all excluded from the landmark low-risk trials. As you can see here, a large number of patients were excluded, 34.2% screen fail rate in PARTNER 3 and 13.4% in Eberhard. Here we can see the transcatheter replacement in low risk in bicuspid, and we look at the Eberhard low risk bicuspid registry. On the right side here, good data. Device success, 95%. Severe patient prosthesis mismatch, only in 7 patients or 5.3%. Excellent. This is what we need. And mean gradient, more than 20. In this patient population, only 1.4%, or 2 patients out of 146. And not to speak about the hemodynamics, 1-year outcomes in Eberhard low risk, excellent valve hemodynamics, and very good data on paravalvular regurgitation. And basically, PARTNER 3 mirrors these results. So both valves are very successful in treating the bicuspid morphology. However, as we know, these clinical studies reflected only a selected group of patients. In order to really broaden that indication and recommendation, we have to wait for, we have to carefully consider when we submit a patient to TAVR, because the outcomes in surgery has been great. By now, it is approved and it is not off limits. Both PARTNER 3 and Evolute low-risk trials excluded also patients with coronary heart disease. Equally important when you move into younger patients with an opportunity or chance that we have to get back into the coronaries. So therefore, it is very important when we look at the need for commercial alignment for all our TAVI patients. And that is particularly important for the self-expanding Evolute platforms, Portico, or for the Neo, for the Actuate Neo 2 or Neo. Very important that you pay attention to commercial alignment. What is commercial alignment? Commercial alignment means that the commissures of the implanted valve should exactly match the commissures of the native valve. Very important. We know how to do it. In a large majority of patients, we can see this by using the flash port facing at 3 o'clock. And here, the current coronary access strategy by device design, short stent frames and large frame cells, and procedural techniques, as I said, commercial alignments for self-expanding valves. Future focus, better markers, and new design. Consistent alignment is achievable across all contemporary valves. Last slide, and in summary, my dear friends, both Evolute Low Risk and Partner 3 trials provide robust evidence for the safety and efficacy of TAVI in patients at low surgical risk. Age and durability are key unknowns following the low-risk TAVI trials. Preserving coronary access and anticipating the need for post-TAVI PCI in patients with coronary disease is a key consideration for TAVI in this patient cohort. Patients with bicuspid anatomies are an important sector of the severe aortic stenosis patient population, and more studies are needed to support the expansion of TAVI into this portion of low-risk patients. With that, I would like to thank you for your attention.